Hello and good morning everyone, and welcome to our 13th webinar for this semester. My name is Jeff Buckley and I'm the director here, and it's my great pleasure to introduce myself today to speak with you on the topic of long and short brief interventions. Now, before I do that, however, I'd like to acknowledge the traditional owners of the land on which today's webinar takes place and pay respect to elders past, present and future, and extend that same respect to any Aboriginal and Torres Strait Islander joining us online or in person here today. So this is a last-minute presentation to fill in for Dr. Jeremy Haler. He was supposed to talk about his recent trip to Portugal, but unfortunately Dr. Haler had to return home for family business, but he will be presenting that webinar next Wednesday. So at the last minute we've slotted this one in just to keep the show on the road. But it's also good because we've got a whole bunch of new tools and resources that are just ready, as if literally yesterday, that we can launch, which are brief interventions, hence the reason why we've decided to shoehorn this presentation in. But rather than just launch tools, we're going to have a little bit of a chat about brief interventions, and hopefully by the end of this hour, just know a little bit more about how to better communicate with patients affected by substance use disorders, understand key elements of brief interventions and its evidence base, just have a quick tour through some of the key BI screening and assessment tools, understand the flags and frames approaches, which are the most common kind of BI, frameworks. And lastly, talk about these new tools and some tips for practice, essentially. A couple of little practice tips that you can use the second you walk out of here with your next client or patient. So yes, hopefully it's very practical and you'll get something out of it that you can use in your workplaces. So just while you read that comic, I just want to make a disclaimer that I am not an expert in brief interventions. I'm not an academic. I have not researched them. I understand a little bit about them, and I kind of understand that they have that there's quite a lot of evidence around their effectiveness. But please do not think that I'm the font of knowledge of every brief intervention in substance use realm in the world, because I am not. But I will offer you what I do know as part of this. But I also do know that this approach does not work, and that's kind of key under the particularly under the motivational interviewing kind of approach, that just telling people and shaking your finger and saying no is not an effective way to encourage or implement behaviour change. So what do we know about brief interventions? What are they at first? Well, it's a time-limited, patient-centred approach that focuses on changing behaviour. The World Health Organization defines it as practices that aim to identify a real or potential alcohol or other drug problem and motivate an individual to do something. And for a person who does not realise that there is a problem, the goal may simply be to get them to start thinking about the issue, their substance use, and to come back for another visit. So it's quite a simplistic concept when you boil it down. How brief is brief? Well, an ultra brief intervention can be anywhere from a couple of minutes in one session. The more standard kind of concept of brief intervention is anything up to an hour, but generally 30 to 40 minutes for a single session. Or there's this concept of brief therapy or of extended BI, which is maybe up to an hour again, but there might be multiple sessions for it. So there are different kind of understandings or conceptualizations of brief interventions. It's important that brief interventions is not like a concrete specific thing, and it's not a homogeneous entity, but as a family of interventions varying in duration, content, targets. And different people are responsible for their delivery in different ways. So it is a broad umbrella term for a bunch of, techniques, strategies, motivational or change-inducing kind of techniques that clinicians might use with patients in various contexts. So in a nutshell, they can last from a few seconds really to an hour. They're generally opportunistic and identified through routine screening. They're more effective at people who are at risk of developing dependence rather than those who are already dependent or experiencing severe substance-related harms. So they're more effective at those people at the earlier stages of the trans-theoretical or stages of change model, and should be repeated wherever possible rather than focusing on a single session. That referral and follow-up is a really key part of BI, which is often missed when people are just thinking about the intervention I can deliver here and now. So what's the evidence base? A lot of the evidence is around risky drinking and alcohol consumption. There's mixed evidence about their effectiveness in emergency departments and trauma settings. They have noticed a significant reduction in alcohol consumption at 3 months post the brief intervention in emergency departments, but that effect wears off after 6 to 12 months. There is some effectiveness in reducing risky drinking and motor vehicle crashes where alcohol is involved, and some effectiveness in their increasing clients' readiness to change. But there's something about the context of the crisis nature of emergency departments which suggests that BIs aren't very effective in that particular setting, or their effectiveness is limited and wears off quite quickly. The good news is that they have a lot of evidence in primary healthcare and in GP kind of settings, and is as good as an extended intervention. And there's been a couple of Cochrane reviews that have shown this. There was one in 2007 that shown that patients who received an alcohol screening and brief intervention consumed 4 fewer standard drinks per average. That was 6 for males and 1 standard drinks for females. So that was the evidence in 2007. But however, what they did find is that they couldn't replicate that kind of level of success out in the real world, that it was very efficacious within the controlled clinical trial settings. But I guess because of the people who dropped out of those kind of controlled clinical trials, their effectiveness was difficult to replicate in the real world. And then there was a number of studies that showed no or minimal effect of an alcohol screening or brief intervention afterwards. So that prompted Kainer and Bayer to do another Cochrane review, a systematic review, just this year. And that was an updated meta-analysis of 34 studies that still showed evidence of reduction in drinking after 12 months, but realistically it's more likely to be 2 Australian standard drinks. So about 20 grams of alcohol is the average reduction, and there's no difference between men and women. So that's what the evidence now says around alcohol. And so why is it? People think, a lot of us will understand if we've conducted a brief intervention that the assessment process itself might just be the magical active ingredient. Simply the process of undertaking the conversation is enough to prompt behaviour change in the individual. But we also know, and this is really strong, is that its value and its strength is derived from the context of the therapeutic relationship, the nature of the intervention, the bonds that are formed between the clinician and the patient and client are just as important as the process or as the thing itself. And again, it's the simple act of having the conversation, not shying away from it. So what else makes a BI work? And this is what, I'm reinforcing upon it, just made Project Match really identified as that quality and strengths of the collaborative relationship is the strongest predictor of a positive therapeutic outcome. And we would all know that, it's there was the United Nations Office of Drug Control a few years ago presented at Winter School. He described the therapeutic relationship as like the petrol in a car. It doesn't determine where you're going to get to, but you won't get anywhere unless you have it. And I think that's a really good way to think about the importance of having that relationship and that therapeutic bond before you can hope to achieve any other kind of therapeutic outcome in that setting. The 4 elements of that therapeutic alliance is a positive bond between patient and clinician, the collaborative team approach, agreement about goals of treatment, and the task of the process is about how to meet that treatment goals. They're the 4 key elements of that therapeutic alliance. And essentially they all follow a fairly standard, uniform kind of structure. They're a bit of a formula. How you do the formula can, in terms of its detail, differs, but essentially it's an initial screening and assessment, followed by education and feedback based on that screening and assessment, and then a follow-up and or referral. That's the standard process. What differs essentially is which screening and assessment tool you use and what education and feedback model you utilise, and whether or not you're the person who can do the follow-up, or whether it's not within your role that it requires referral outside or elsewhere. There's a whole bunch of common AAD screening tools that are, used more heavily within the alcohol and drug world. The Assist is developed by the World Health Organization, and there's a couple of other, Assist Lite and Assist Y. That's probably the most well-known and universal one. We're all very familiar with AUDIT, the Alcohol Use Disorders Identification Test. There's an AUDIT 3, which is a 3-question tool, which you might do, and then if it scores highly, you might then do a full audit. Some people use, I haven't heard of it too commonly, the DUDIT, or the Drug Use Disorders Identification Test as well. The Severity of Dependence Scale, the Indigenous Risk Impact Screen, and Substances and Choices Scale for young people. People are most familiar with these. I guess these are the ones most people tend to use in their clinical practice. There are a few others that other people can use depending on the context. And we've got these all uploaded onto our website, which I'll show you shortly, so you can have a look at them. We'll have a look at a couple of these today in a little bit more detail, just to get a picture of them. But choosing the screening tool or assessment process you use is really important, and that context is really critical. And it needs to match the client or patient's presentations. And in the literature, they talk about opportunistic BI or specialist BI. And opportunistic BI tends to be when the client is not seeking help with their AOD use, okay? And this tends to happen in, say, primary healthcare settings, maybe sexual health clinics, other social welfare service settings where somebody is AOD trained or understands how to do it, but the client is not necessarily there seeking an AOD intervention. And as you can appreciate, the way to tackle that conversation is a lot different for someone who comes in and goes, "Hi, I'd like to talk to you about my alcohol use." And really quickly, if you are in that, and I don't know who's on webinar land, I guess in this room there's a mixture of specialist people who this is bread and butter, and you're not going to learn a hell of a lot from me today. But if you're in this room and you're a bit new to this world, or you're in a primary healthcare setting, then this possibly might be more interesting for you. If it is an opportunity BI and the client or the patient isn't there to see you about their alcohol and drug use, the notion of timing and acceptability is really, really important. And most people kind of expect to be asked about their substance use if they're registering for the first time for, say, to enter your GP surgery, or it's their first appointment and they're filling out the big clipboard, and they understand that their substance use might affect whatever they're signing up for in some ways. So certain health checks such as diabetes, hypertension, or maybe it's around a mental health assessment, people would expect to be asked around their substance use and are much happier to engage in a conversation because they see the links. But if someone's coming in because they've cut their finger on something that wasn't necessarily on Saturday night at 3 a.m. in the valley, and then all of a sudden you ask a deep kind of alcohol screen, they might go, "Hang on, I'm just seeing you about my finger, this doesn't make sense," and are less likely to engage. There's a lot of detail on this slide, but it's pretty good in terms of this opportunistic BI to look at what are the strategies to overcome that. So establishing the clear reason why you're going to have this BI, why you're going to talk about their alcohol or other substance use, and the impact that might have on any other kind of health problem they might have. And kind of packaging it up in a general health promotion chat, talking about smoking, diet, exercise, makes the alcohol or cannabis or whatever chat feel a bit more normal and pedestrian rather than somebody feeling they're being targeted. A collaborative consultation style using a friendly tone and avoiding interrogation is really, really important. And also negotiating the agenda, like instead of going, "Now we're going to talk about your alcohol uses, would you mind if I ask you a few questions around how much you drink or your patterns of drinking," after their primary concern has been addressed. And lastly, we need to appreciate that a lot of people feel quite embarrassed or don't want to disclose their substance use or drinking. They feel that there's some moral judgment or some sort of, a lot of judgmental kind of, they're going to get the finger wag. And so asking permission and using sensitive language is really, really important to make that intervention more palatable. Like I said, ASSIST, the alcohol, smoking and substance involvement screening test, is one of the most comprehensive kind of tools that does a full screen of all substance use. One of its kind of critiques, I guess, is particularly in the Australian context, is that it does link all of the psychostimulants together as one. So methamphetamine, cocaine and MDMA, whereas we know that patterns of substance use, particularly around methamphetamine, is very different to MDMA or cocaine amongst our population group. So you might lose a little bit of kind of detail and fidelity in that particular screen. We also know that the ASSIST Light kind of loses some of its kind of useful effectiveness because it's a bit too light. And so whilst it's the most comprehensive, there are a lot of challenges with introducing it. The biggest challenge we hear about is that it's so long that if someone has got a quite an extensive polysubstance use history, it's a half an hour just getting the basics of what they've consumed and how often they've consumed before you even get to talking to them about it. And that can be a real killer on the therapeutic alliance. Nevertheless, it is a worthwhile tool to be familiar with. And I just wanted to let you know, if you haven't discovered this in your travels, around the Atoda electronic assist, which is freely available online. And so if you want to learn about how to do a brief intervention, this is a really good tool just to play around with, and even to do it on yourself or on a case study or on a client that maybe you've seen. So you can get handouts of this, and I believe for participants online, if you click the little folder button, you can have a look at this presentation and get the notes. But it just basically has the whole assist tool done digitally. And this is kind of like the question one, where you ask if you've used any of these kind of substances. It's got a whole bunch of tips around pop-up boxes that give you advice on the right-hand side. They can hover over if you're having the intervention and you want to explain it. So there's a lot of explainer notes all the way through it. And then once you've done the full screen, it'll pop up with the risk scores and tell you what your risk score is for each of the substances and what those risk levels means. So it's quite a handy, well-conceived and comprehensive tool. And then once you've identified if they need an intervention or not, the intervention pops up for you. So you've got this checklist on your screen to go through in terms of, how to go through the steps of doing the brief intervention. It does the decisional balance. It talks about a little bit of, some readiness rulers or concern rulers. And then there's a whole bunch of take-home resources that the World Health Organization have developed, which you can download through this app that you can print out and give to the client or patient and take it away with them. So rather than me going through this in great detail, I'd rather just show you that exists, and I encourage you to have a play around with it and get a fuller understanding of how the assist could be used in real life. These are some of those self-help strategies, and this is a risks of injecting card if the client admits injecting substance use that you can print out to give as well, or you can use your own. They've even got this handy video. So under the they invested some of the money out of the recent National Life Strategy to develop a methamphetamine-specific assist tool. And this video here shows a brief intervention in the flesh. So you can watch that if you just wanted to see the art of it by the manual or by the textbook. So there's all the details there, the Assist on Ice e-manual. So that's a really quick look at, opportunistic BI in like a primary healthcare setting. Most of us, if you're in this webinar, are probably specialist AOD and more likely to do it as part of your day-to-day practice with clients. Sometimes with patients who it's their first meeting and you're not sure if they're going to come back, they're not sure if they're going to come back either. You're checking it out, and this is your opportunity, in case you never see them again, to hopefully leave a bit of an imprint and assist them with some of their decision-making and motivation to change. Obviously, one of the first things we do want to know when any client comes and sees us for the first time is whether it's self-initiated, legally mandated or socially mandated. If they're there voluntarily, that gives you a sense already about how amenable they are to a conversation around change. But if they're legally mandated by courts or socially mandated by a parent or a girlfriend or a boyfriend, you've got that barrier to address and deal with first. And if you do identify that they are mandated there, we really encourage you that you acknowledge it, normalise it, explore their feelings about it and the nature and context of this external motivation before you dive into any other kind of intervention. Geez, it must sucks coming here if you really don't want to. I understand that this might be a bit of a drag on your day, but hey, look, we've got this time now. If you want to make use of it, I'll see if I can be as helpful as I can. And maybe tell me about why X has sent you here. What brought you here? Why has the court ordered you to come and see me? Why is your girlfriend threatening to break up with you unless you come and have a chat with me? They're really good conversation starters as part of the BI. Okay, so in terms of key kind of BI approaches, the ones I'm going to really look at quickly today are flags, frames, and brief motivational interviewing. Is everyone familiar with these? They've been around for a long time. Flags essentially stands for feedback, listen, advice, goal setting, and strategies. And it just kind of, again, steps you through some of the processes of conducting a brief intervention. It encourages you to, raise the issue by linking to presenting problem. This is why we're going to have this discussion around your alcohol use or cannabis use. You would then conduct the screen, present information on how the patient scored, and provide normative feedback, so comparing their rates of use with general population norms. And we encourage people to use patients' words wherever possible. So we do know that people like to think that they're normal and are very surprised when they find out their substance use is out of the norm of the rest of the world, particularly if their whole social or peer group or family lifestyle or family home is very drug saturated or alcohol saturated. And we do know that just letting people know that they're drinking either in excess or more frequent or using more frequently than the average population in and of itself can prompt behaviour change in an individual. And that's why they say that the assessment and feedback is often potentially the most impactful part of the BI. Flags encourages us to do more listening than talking, to let the patient respond to feedback without interruption, to find out what it feels like to hear this is their scores. listening for occasions when the problem might have been less of an issue and what strengths that will aid them in changing the behaviours, using a lot of reflective listening to convey that you're understanding and following them, and asking the client to provide specific examples of the effects in their life. There is an advice component, particularly if we've only got one session, particularly harm reduction or basic psychoeducation around the substance use, and making sure we clarify the understanding of the patient if they're unfamiliar or they look a bit kind of puzzled by what you're saying. And importantly, taking note of what the patient nods and kind of thinks is acceptable, and because you know that if they do come back, that's probably a place to start for your next session. Goal setting can either be patient or clinician identified. It's better if it's patient identified, but sometimes that is not always possible, depending on the kind of the capacity or the age of our client. But we do encourage you to get to more specific and realistic goals rather than I'm going to quit next week. So helping them to kind of narrow that down to something more specific can be a useful discussion. We need to build self-efficacy and belief that people can make change, and so encouraging them that a little step is important and that change is difficult and that needs to be understood. And if they don't want to make any goals, just acknowledge that the information is an issue of concern and invite them back whenever they're ready to talk about it again. If they do have goals, the next step is then strategies, which is putting the detail to the goals, how they are going to achieve them. If they're unrealistic, trying to narrow them down and specify them more closely, and looking potentially what's worked in the past or not worked in the past as a way to kind of identify which is the best way forward for this new attempt, if that's indeed what they want to do. We'd always encourage and congratulate them for getting to this stage, discussing who they have to support them, providing a referral if they need to, and the balance of normalising a slip-up or a relapse without condoning it so much that it becomes normalised if they do find themselves in that situation. Yeah, so that's the flags. It's pretty straightforward. I guess it is a good little mnemonic to have in your head to go, okay, am I doing all of these things as part of that kind of maybe half an hour or 1 hour session? Frames is not a lot different. It does have that same kind of component of the feedback, advice, the listening and empathy and self-efficacy is there, but what it does emphasise in frames is this notion of responsibility that a lot of people find useful, that, well, really only you can make changes to your substance use. You can't really, no one else can really do this, so if this is something you want to do, this is a decision you need to make. And what you do with your substance use is up to you. That it does emphasise that component of responsibility. And this one also really sells this notion of a menu, that a good clinician will have a bunch of tools and resources at their fingertips that they can present like a smorgasbord to the clinician to pick and choose, to the patient to pick and choose what he or she is interested in and is more likely to stick for them. But the rest is kind of similar to some extent to the flags approach. I'm whipping through this because I want to get to the tools that I talked about and give you time to have a look at that. This is the 5A's model, which is generally used in primary healthcare and GP settings. Again, it's ask, assess, advise, and agree, assist, and arrange. What we find is that there's a lot of evidence, particularly in primary healthcare and maybe in your own circumstances, where we're very good at doing the screen and providing the scores, and then we're very quick to do the refer. And that what we find is that there's not a lot of time or effort that's necessarily done in the actual intervention itself. We know that that's a characteristic of busy kind of GP clinics where you've got 15 minutes or half an hour tops, and getting into the detail of a long intervention is not possible. But I also encourage all clinicians to to sometimes sit with some of those awkward silences, or to persist with some open-ended questioning around the feedback or hearing how they've interpreted their scores as part of that brief intervention to maximise its effectiveness, rather than just going, the conversations feel like it's stalling a little bit, let's just offer you another appointment or refer you to someone else to kind of have the conversation there. All right, I just want to quickly tell you about a couple of structured package kind of brief interventions that exist in the world. Quick Fix is one that I'm not super familiar with, although I work quite closely with Professor Leanne Hyde, who is developing it with Dr. Catherine Quinn. But it is a brief motivational interviewing based CBT coping skills kind of two-session model that deals with both alcohol and drug and comorbid mental health problems. Leanne kindly sent me some slides to include here about what it is. It is focused on young people, and they're doing a lot of trials at it around various sites in Queensland, including with Withdrawal, with the Gold Coast Chill Out Zone, with Chaplain Watch, and also potentially with ADIS here as well. But what Quick Fix looks at is that personality is one of the vulnerability factors most consistently related to alcohol use. And it looks at these different kind of substance use risk profiles, which are quite interesting, around people who are anxiety sensitive, depression prone, sensation seeking or impulsive, and looking at those personality types to go, okay, if you identify the primary drive behind your substance use is this, then let's tailor an intervention that's most likely going to match with your personality type. So it's an interesting kind of approach around the motives of substance use. So anxiety sensitivity is a tendency to believe that bodily sensations of anxiety or fear will lead to illness, embarrassment, or heightened anxiety. So we know that that is a prime kind of motivator for substance use, both depressants and stimulants. Depression proneness, that tendency to feel sad or depressed or hopelessness is a really key one. Sensation seeking tends, whilst it might be a key across a lot of people, you'll probably find more sort of recreational users or people who use in more, say, festivals, events or party scenes to enhance their enjoyment of events and to experience novel experiences. And impulsivity is people who have reduced capacity to inhibit a reward-related behaviour, and they act often without thinking, like it's more subconscious kind of motivations. So looking at those, they would use a screen, a substance use risk profile, to work out what sort of personality type that individual is or that young person is, and then conduct two sessions, an initial session and a follow-up session, 30 to 40 minutes either face-to-face or over the telephone for 30 to 40 minutes. So it has the key kind of ingredients of a brief motivational interview. There's the assessment, initial assessment and feedback, so motivational interviewing skills, goal setting, particularly for harmonisation or change, some personality risk feedback, so that's a little bit different around what your personality type means that your risks or your vulnerabilities are, and coping skills based on that personality type. And here you can see a bit of a breakdown around the coping skills training, the interesting component around, depending on what personality type, the things that you might do to cope, in terms of your substance use and that personality type. Some of these strategies might be familiar, such as depression coping tools, challenging pleasant scheduling and gratitude, abdominal breathing and mindfulness for people who experience anxiety, the stop and think kind of for people who are impulsive. And so these are some of, we kind of use them maybe intuitively, but this one is trying to, I guess, structure it more around that personality-based brief motivational interviewing frame. So yeah, they've published on this. There's a lot. They have found some good evidence for alcohol and cannabis for young people at 1, 3, 6, and 12 months follow-ups, and they've had really good retention in the study as well, which is really pleasing. And all groups have improved over time. 50% reduction in alcohol use and related problems. And personality targeted coping skills had stronger effects at 1 or 12 months follow-up. So if this is interesting to you and you're interested to check it out, contact Leanne Hydes, or you can contact her through us or through ADIS, because Holly Wilson from ADIS has worked with Leanne on this particular kind of intervention. But it is being rolled out and has potential some promise, and we're looking to potentially partner with them to train this intervention next year. Okay. Just to let you, I'm not going to talk about this now, but are people aware that Martin Swift and Copeland developed an adolescent cannabis checkup a number of years ago now that is still available online? It's a 2-session kind of assessment and feedback session for young cannabis users, followed by a single session of CBT. And then lastly, we've got the SBIRT, which is an American kind of model. The Americans have just done really well to coin stuff we do in general practice, package it up and sell it. But essentially SBIRT stands for Screening, Brief, Interventional and Referral into Treatment. So if that comes up, look, it's essentially a brief motivational interviewing with a referral component. But if you wanted to research that, SBIRT is one that you can do as well. So there's some of the key kind of motivational interviewing packages that I'm aware of that you can kind of access. So the Assist, the Quick Fix, Expert, the Adolescent Cannabis Checkup, and Expert. There are a whole bunch of other little ones, but generally they tend to be more kind of techniques or tools. What I'd like to look at for the next, say, just 15 minutes is give you quick tools around or some exploration of brief intervention within a motivational interviewing frame. So yes, unsolicited advice is the junk mail of life, is a nice quote. If anyone has noticed that as soon as somebody tries to tell you what you should do, the first reaction is to do the opposite or to kind of put up a bit of a barrier around it. And that's the underlying principle of motivational interviewing as well, is that we know that people are more likely to act or implement change if they can articulate it and verbalise it themselves. You listen to your own evidence more than you listen to other people's evidence. And the art of this approach is to get people to articulate that themselves. I am not going to go through the stages of change with such an advanced audience today, but we all know that this is a bit of a cornerstone framework to the alcohol and drug sector and our work. This is a better stages of change model that we've had permission from the Titchikala community in the Northern Territory to show to you. It just uses a bit nicer language than the trans-theoretical model in terms of pre-contemplation being not worried, contemplation being thinking, and here you can see the individual close to the centre near the grog and disconnected from family out on the outside ring of the circle. But as they start preparing or trying, they might move closer to family and community till they move into an action phase where they are more connected and further away from the grog, and eventually hopefully into a maintenance or sticking to it phase, and avoid not the relapse phase, because that's such a bad language, but the learning phase, which we think is a lot nicer in terms of understanding the educational opportunities that slip-ups or lapses can afford an individual attempting change. So brief motivational interviewing essentially goes, find out where someone is in the stages of change and match your intervention to that particular stage. How do we find out where someone is in a stage of change? We ask them. Yay, yes, we ask them. And there's a number of ways you can do that, and you'd all be familiar with this, I'm sure. Change rulers are a really good one. You could go, on a scale of 1 to 5 or 1 to 10, how worried are you about your substance use, or how concerned are you about your drinking? And how ready are you to change your behaviour right now? That score alone will give you an indication if they're at pre-contemplative contemplation or more in a planning kind of stage. A decisional balance tool is another way that we can find out if somebody, what their kind of stage is. The good old, what are the good things about drinking or substance use for you? And you'll find if they've spent half an hour extolling the virtues of all their substance use and how wonderful it is, and then you get to the not so good things and they say, well, it's expensive and I'm a bit tired afterwards, you kind of know that they're very much probably in the pre-contemplative phase. But people who like to use a counselling with neutrality approach would like to use like a decisional balance approach to their motivational interviewing style, because it doesn't assume that they're just going to focus on all the negative components of substance use or drinking and ask in a very interested kind of way about what's happening for them. And we do know that it is particularly helpful for pre-contemplative and contemplative patients only. If somebody's decided they do want to make change, we suggest it's not so helpful. We don't want to remind people about all the good things that they're potentially moving away from. But if you're trying to, engage and develop a therapeutic alliance with someone you've never met, it could be a good way to start the conversation and build that connection in a way which seems very neutral and non-judgmental. And it also gives you key clues as to the reasons behind the substance use that you might need to address in future work. So that's why it's recommended, but if you already know someone's moved beyond that stage, we recommend you probably focus more on that focusing stage and the planning stages of work. So once you know where someone is in that stage of change, we encourage you to respond accordingly. So this one slide is alcohol and drug treatment in one handy PowerPoint. You can all read that, got it? Cool. Now, I'll go into a little bit more detail, but essentially some of the key bits around a brief intervention particularly are effective in the pre-contemplative and contemplative stages. And we know that if you identify someone is not ready to address their substance use, your real focus at this stage is building trust and relationships. You really want to avoid confrontation. That therapeutic alliance is key. This is where you'd explore other issues known as 4Ls. And if people aren't aware, there's this great tool called Roizen's 4Ls model that people can either use on a piece of paper or in their brains in a session with someone. And 4Ls basically reminds you to talk about liver, lover, lifestyle, or law, with liver being your health effects or your mental health effects, lover being your relationships, lifestyle being the, and I use the Mars analogy, work, rest or play, so your job, your study or your pastimes and hobbies, and law obviously being legal impacts. So if somebody has no real kind of desire to change their substance use, have a conversation about this and try to find out if there's any links between their substance use and potentially any problems that they haven't connected with other aspects of their life. And that might help create some opportunities to identify any harms that might be occurring that might maybe touch a conversation that moves more into contemplation. Just letting you know that in Western Australia, I think this reference is wrong. Casey, oh no, maybe it's right, Casey and Keane. I think we had to update that. But there's 3 other L's that have been proposed for working with Aboriginal and Torres Strait Islanders, and that is this notion of land, so connection to country, law, which is connection to stories and Aboriginal law, and loss, which is sorry business and grief and loss with community and dispossession. So looking at the impact of substance use against those 3 components of life is the extension of the 4Ls for in an Indigenous context. So once you've done 4Ls, you can also encourage self-monitoring and personalisation of risk. And lastly, and the key thing obviously, which is really important for pre-contemplative clients, is harm reduction tips. And basic psychoeducation and harm reduction would cover, this is just a list I've kind of come up with, some of these kind of things. Just have you considered reducing or abstaining from your substance use? A really important question to ask. A lot of us sometimes don't even think to ask because we see the substance use as so at such a high level that we don't consider it an option, but there's no reason why we wouldn't ask this question in a counselling context. Safer routes of administration, looks around decreasing health risks for physical, including overdose or mental health risks, environmental factors, planning ahead, avoiding risks, vulnerable situations, not using alone, not driving under the influence, practicing safe sex, avoiding legal harms, and looking at some of those 4Ls in terms of risks to relationships, employment, life goals, etc. So that's that's what you could do in one session, is just go through this list and have a conversation about each of these to make sure the client has got as much understanding around ways to reduce harms while they're still in the pre-contemplation phase. They also proves to you that you're a good person who's not there just to wag your finger at them. They're more likely to come back and see you when problems do emerge because you're that person that was quite honest and open with them and wasn't trying to mess with them too much. Again, we want to make sure that we identify harms that are most likely to occur early. Generally, ones that affect appearance or performance are ones that are most important to people. Long-term kind of chronic disease or organ failure doesn't tend to resonate with a 16-year-old methamphetamine user who's probably more concerned around skin, teeth, inability to get erections. That sort of things is probably more likely to have an impact, and discussing when it's a problem. If we think our clients are in more of a contemplation phase, this is when we would validate that lack of readiness, understand that it's a big thing, that this, I would, but the but if kind of conversation that often happens, but building motivation and confidence and ability to change. And this is where the brief motivational interviewing really comes into its fore. And we would always say, if someone says they're ambivalent, you can always say, it's great, that's being one step closer to changing is being ambivalent. So you're on the pathway to making a positive change. I am not going to summarise brief motivational interviewing in 5 minutes. I think you all kind of know what it is, and you can access our training if you like. I guess some of the key points I would probably make is that the spirit of MI is just as important as the technique of MI. It's a very much a partnership approach which has acceptance, compassion and evocation at its heart. For us, it's about resisting the righting reflex. It's resisting the urge just to tell the client what they need to do and everything would be okay. To fix the problem, it's resisting that urge to do it. It's more focused on understanding the patient's motivations, listening to them and empowering to make the change. And they talk about focusing on change talk and reducing sustained talk. as being kind of the key kind of components of effectiveness, and trying to nudge people towards change that moves from desire, ability, reason or need, more through to being able to, or taking steps, a commitment to, and then actually taking steps to change. That's the goal of MI. It uses OARS, or open-ended questions, affirmation, reflection and summarising as the key strategies to achieving that goal. And so again, not asking closed questions, trying to get the person to speak, using a lot of affirmation and acknowledgement and reflection and summarising as core tools to help people through that conversation. And the one last trick I'd like to share with you today before we go is the 4-column diagram. Has anyone not heard of the 4-column diagram? Has everyone used the 4-column? No? Okay, we're going to have a little tour through 4-column. It was developed here in Brisbane by Marina Birmingham in the mid-80s. She's a psychologist who still practices in Brisbane. And was it AID or was it Hot House? I'm not sure. Hot House. It was in Hot House. It was part of here in Queensland Health. This is a homegrown tool. And I'll just quickly describe it, because even though it was developed for adolescents, I believe it's got applicability across all age groups because of its simplicity. And it uses the decisional balance kind of tool to help that motivational interviewing kind of process. Here's a case study we'll use to tour through the tool. Mike is a 32-year-old labourer. He doesn't think his drinking is a problem, but says he drinks after work with mates and regularly on weekends. His drinking has increased since he lost his full-time job and began casual work. His wife has threatened to leave him as he's getting aggressive when he drinks. He's just received a drinking under the influence charge and has been taking days off work because of his inability to get up in the mornings. He is concerned about his finances and tends to drink when he thinks about them. He says he feels like a failure and drinking makes his worry goes away. So that's Mike. So this is the structure of a 4-column diagram, a really nifty trick, and you can keep a printout of this kind of table in your top drawer and pull it out with someone, and we've got one of these online you can download and use. But the 4-column diagram essentially sits across 2 major kind of columns each. On the 2 left we have the being sober or straight, and on the right we'd being the pissed or high. Now I put them in inverted commas because I would encourage leaving that bit blank and asking the client or patient to pick whatever word they want. So what do you call it when you're intoxicated? And if they say pissed or high, write in that. What do you call it when you're not? Use their word. That gives them ownership over the tool. The trick of the 4-column diagram is actually to start in the 3rd column. That's the main thing to remember. And then you go to the 4th column, then back to the 1st, and then to the 2nd. And it does the decisional balance on both the being straight and being intoxicated angles. So here you would go, "G'day Mike, so tell you, what are the good things about being pissed for you or being intoxicated for you?" And Mike would say he likes socialising with mates, he forgets about his money troubles and it makes him feel better. There might be a bunch of other stuff that comes up, but there's some of the common ones. Okay, Mike, once you've spent a couple of minutes on that only, what are the not so good bits about being intoxicated? And hopefully Mike would reveal his drinking under the influence charge, the fact that he's noticed he's getting aggro, his wife gets angry, his boss gets angry, that's why he lost his job, his permanent job, and it's expensive. You want to spend a lot more time exploring this, going into detail and finding out some of the reasons, motives and details of it. We would then move into the 1st column and go, all right, on the flip side, Mike, what are the good bits about being straight for you? And this is often a mirror kind of opposite of the 4th column, and he would say, well, I'd have more money, I'd feel better, my wife wouldn't be so annoyed, and maybe I'd be more likely to get my job back. And then we would go, so Mike, lastly, what are the not so good things about being straight? And this is where some of that other key stuff might come up. My feelings of being a failure since losing my last job, maybe feelings of shame and embarrassment, particularly with my wife and friends for being unemployed, and maybe I've got some feelings of depression. This column is critical because we can kind of see that these are the motives behind a lot of the problems that Mike is experiencing. And you can do this, and the art of it is to go, hey Mike, so it looks like these are all of the problems that you currently face in your life. Your drinking is a solution to some of those problems, but it's coming up with all of these consequences. But the good news, Mike, is that you don't have a drinking problem, you've got a being straight problem. And if we can deal with some of those issues of you being straight, some of your drinking problems might go away all by itself, rather than just focusing on the alcohol. So that enables you to have that conversation, to build a bit of self-efficacy that that Mike hopefully can make some changes, and it gives you a clue to your treatment plan, because these are the things you're going to work at in order for the alcohol to not be such a reliance in Mike's life. So, and it's also a very visual tool. You can have it out in front of you. You can take a photocopy. Mike can take it home. You can keep it in your file. A very kind of handy tool for a pre-contemplative or contemplative client. Sorry, it's a handy tool for a contemplative client to thresh out some of those reasons and inform future steps. So yeah, I won't go through these, but there's a whole bunch. These are in the slides about what you would do if someone is in a preparation, action, maintenance, or kind of a relapse prevention or management stage. I've run out of time to look at those, but I think they're pretty kind of standard to what a lot of you would do in practice anyway, around that kind of goal settings, finding supports, getting skills around kind of refusal skills, mindfulness, exploring alternatives, and then relapse prevention, and discussing coping strategies and reassessing that initial motivation. So you can look at that in your own time. But that would characterise, if you had one session and you knew that your clients were in that further up bit, that would be what you would focus on within that one session to make it most worthwhile and useful to their stage of change. All right, this is the fun bit where I get to show you all of the hard work that we've been doing. We've got a whole bunch of new check tools, which are ultra brief interventions so you don't have to remember that whole presentation. We've got these wonderful colour A3 kind of tools that you can download and print as of today. We have alcohol check, cannabis check, and benzo check being launched today to accompany meth check, which we released probably about 2 years ago now, when we were first funded under the Queensland methamphetamine response, and opioid check, which we released only a couple of weeks ago. And they look like this. Do you want to pass around some of these copies around the room, Michelle, so people can have a look at them? They follow a very similar kind of structure. This is alcohol check. This is the audit C on the left-hand side. So you do a quick screen. It then tells you how to do the feedback. Then up the top, it gives you some normative feedback around what their level of drinking is like in relation to their potential health risks. It's got a little money calculator, so we know that money is a big motivation for change. So just getting somebody to work out how much they spend a week, and then extracting that to a month, and then extracting that to a year to go, wow, I can't believe I spent $15,000 on alcohol last year. Imagine what you could have spent that on. That can help to really jog people's kind of thinking of motivation. There's the good old-fashioned decisional balance. We've got some readiness to change rulers at the bottom. And then, this goes into more detail. And then on the back, depending if they're pre-contemplative, you can just do some harm reduction chats down the left. So there's a little table where you can suggest harm reduction things and find out if they're already doing them or if they might consider doing them. And then we've just got some basic psychoeducation tips around, staying hydrated, mental health, looking after your mates, not driving, having your phone charged, a whole bunch of tips that you can talk at just to prompt the conversation. But if they are contemplative or they're maybe moving into planning stages, there's some tips around the good old-fashioned delay, distract, deep breathing and drink water. There's some advice around any risks that might associate with cutting back or quitting, particularly with drugs such as, say, alcohol or benzos, where we do know there's medical risk for abrupt cessation. And a little spot to do a bit of a plan. So we're going to print these on big tear-off pads, so you can have a pad for each of these in your office, and if it's your first appointment and you're not sure you're going to see them again, you can follow the steps. You can mix and match what you like. You can pick the bits you like and skip over, and they can take it with them when they like. So it's kind of like an intervention and a brochure or a pamphlet all in one. This is cannabis one. They're all slightly different. There's a lot of specific harms around cannabis, so we've included some of the common effects and harms in that little box there. But the rest of it kind of follows the same, except obviously the harm reduction tips are specific to the drug. There's opioid check as well. Benzo check, which was the hardest to do because they are the hardest class of drug to work out how to respond. In the end, we decided to put a severity of dependence scale into benzo check to make that worthwhile, and we talk a little bit more about build-up and half-lives and affecting mood and memory rather than readiness to change, because that's kind of part of STS anyway. There's some, for substances where there's a risk of overdose, we've put some basic overdose advice in it. So yeah, so these are all available, and we'd love your feedback on them. So they're available on our website, and you can find them in our Brief Intervention Toolkit, which is on our website under the Toolkits page. That toolkit has all of those tools, but also all of the screening and assessment tools I spoke about today. So the ASSIST, the IRIS, the SDS, the Substances and Choices Scale. There's a few others. There's audits. We put the K10, the DAS21, all of the response cards. We put HEADS assessment as well. So they're all there, and this is where you can find it on the page. We'd also like to formally launch our withdrawal management quick reference guides. And I believe they're just up the back there. Laura, you can hand them around everyone as well. Just next to our brief interventions is the withdrawal management toolkit. And here what we've done is summarise all of the, I guess, the guidelines and the procedures within the Queensland Alcohol and Drug Clinical Withdrawal Guidelines and packaged them up into handy double-sided single-page reference sheets. Really handy for, I guess, educating perhaps a new worker, or in hospital settings where maybe a treating team or identifies someone on the ward that might be going through withdrawal. Rather than thumbing through the whole withdrawal guidelines to find the right page, you can print this off and hand it to them, and it goes through the actual scales, what assessment to conduct, how to monitor, what are the risks. So it's all kind of there. We do acknowledge that there is some evidence that has emerged since then, and local HHSs might have specific guidelines, particularly around, say, what dosage of thiamine to give someone in alcohol or identified as being alcohol dependent. So people can interpret them locally, but this reflects the current kind of withdrawal guidelines as they stand. So yeah, we've got cannabis, alcohol, benzos, psychostimulants, and the other one. Yeah, the 5 of them. Opioids, yep. We have another toolkit that we launched just last Friday as well. We've been very busy. We've been working with the Communicable Diseases unit in the department and with Quinn to release the Queensland Needle and Syringe Program online toolkit. So this is all training and resources for anyone who operates at NSP. And so this is freely available in the public now. There's an e-learning package. We've got a bunch of videos. We're putting the finishing touches on a safe injecting video at the moment, and also filming a naloxone and Nyxoid videos. So they'll be added to this as they get finished. There is training presentations and PowerPoints, manuals, videos, and the guidelines have been updated as well. So if you operate in an NSP context or just want to know how the program is, you can get your QNSP authorizer training done through here, and you'll get a certificate saying that you are now authorized to operate in a QNSP. So that is all online there if that is something you want to know more about, and we'll be adding to this resource over the coming weeks and months. And because we've done so much work, I'd like to put some special thanks, particularly to my team. Kira Willis, Sam Clark and Jim Hunt have done a lot of work. Everyone's worked on the check tools, but these guys have probably done a little bit more than others in terms of some of the finessing and the details of them. So thanks to those guys for their efforts. Louise Durant, give a wave, Louise, did all of the hard work condensing the withdrawal guidelines into 2-page sheets. So well done, Louise, on producing them. Yes. They're really we've had a lot of positive feedback from them already at SIG last week about how people are using them, so that's really pleasing to know. Niall, you've been excellent in doing... Niall's the guy who does all the graphic design, and we've changed our mind a gazillion times on those check tools, and Niall's been very friendly in his, gritting his teeth and changing something back to the way we had it before we changed it to the way we had it twice before. So thank you, Niall, and a really big shout out to Ben Doherty in our team, who's behind our whole information and design service, who makes this whole website. He single-handedly not did the content, but designed and built the QNSP needle syringe program package just in his spare time, pretty much, as well as doing all of the other coordination of work. So I really want to put a big shout out to my team for all their hard work over the last few months in developing these tools. We have a slip-up tool, like a relapse prevention tool, which is in the final stages of editing. We just did client feedback on it yesterday. We're going to implement those changes and hopefully get that one out in December. It'll be like the check tools, an A3 colour tool, but we're just going to make a few changes on that before we launch it, so stay tuned for that one. That's it. That's brief interventions and a launch of all of our tools in an hour. Thank you very much.